talk is totally different from the earlier interesting talks, and Raghu's talk and the other talk was very impressive. This is not so impressive. PCA in complex LM bifurcation disease. What is a complex bifurcation? I will look into the definition criteria, where the complex current relation is actually one major criteria with any two minor criteria. All the major criteria depends upon the side branch vessel disease. If it is more than 10 millimeters and more than 70% stenosis, if the lesion is actually moderately calcified, multiple lesions and bifurcation angle less than 45 or more than 70 is actually after the three criteria. If you take 2 plus will come as a complex lesion. So the complex lesion is one major criteria with the two minor criteria. So in this case, actually the first discussion is whether it is to be provisional or an upfront two-stent strategy. If it is a two-stent strategy, what strategy? Intracoronary imaging is mandatory or not? If imaging is done, which modality is better? And mechanical circulatory support is mandatory in these cases or not? Calcium modification, is it safe? And role of drug-eluting balloon as Raghu's talk. So these are the questions I have to answer. So the provisional referent two-stent strategy, what is actually happening with the provisional stent strategy? You can have a displacement of carina towards the side branch. That's the major problem. So you know the carinal shift can occur. Basically, in an angiographic side branch compromise is rarely accompanied by a hemodynamically significant stenosis, which is proven by FFR. When you have a low FFR, there is no correlation between FFR and angiographic stenosis. A low FFR group had a significantly high rate of TLF than in a high FFR group. So the angiographic stenosis having no significance, only FFR to be. A planned routine two-stent strategy reduced TLF compared with a provisional strategy in patients with a really complex lesion. So though in complex lesion, ideally two-stent strategy is better than a single-stent strategy. This was in 1 year study, but after 1 year, the cohort is actually provisional and the two-stent strategy having similar result. And what strategy you take? DK crush. Actually, DK crush trial, they have taken DK crush. In that trial, if you look at that trial, definitely the two-stent strategy is better than provisional. But if you go to the EBC mains trial, where the provisional stent and those people who are transferred to the DK crush, actually the two-stent strategy, they did worse than a single-stent strategy. So the stepwise layered provisional stenting is recommended by the EBC as the preferred strategy to treat coronary bifurcation with the intention to keep the procedure as simple as possible and aiming to minimize the number of stents needed in a bifurcation lesion. The provisional strategy is recommended also when use of two stent is anticipated pre-procedurally. A second stent may be required in 5 to 25% of the cases where the two-stent strategy was worse than a single-stent strategy. So, intentional two-stent approach may be required if there is a true complex bifurcation with more than 10 millimeter size. Which technique? You'll understand that the DK crush is the best technique. Since it is an Asian technique, the Europeans and Americans does not accept that. So, what is the preferred technique? Culotte actually leaves metal layers of strut and potential acute closure of MB. In DK crush, a complex procedural step, and you actually T-stenting, and I don't do that, but I do DK or mini crush. Intracoronary imaging is mandatory or not? Definitely problems in angiographic assessment is there, especially for the LMCA disease. And distal LMCA has involved in 86% of the cases with a risk of side branch occlusion, which can be identified by imaging. You can identify the lower lumen wall index, side branch MLA. You can see that calcium arc, spiky carina, all are predictors of IVUS. Again with OCT, you can predict with the carinal tip angle and branch point carinal tip angle. What does imaging gives? It definitely produces the mortality benefit. It is actually seen in Renovate studies showing that imaging is a must, whether it is OCT or IVUS. Both actually reduces the cardiac death, target vessel revascularization and infarction. You just go to this case. Basically, this is an LM complex lesion. You can see that we did a vessel assessment by imaging. Distal vessel was 3 millimeters. The minimal lesion, actually the maximum lesion part was 2 millimeters square. Calcium in the osteoproximal segment. What we did is actually we did a rotablation. both to the circumflex as well as to the LAD, and then followed by, we used cutting balloon, and we did not stop there. We just did a post-cutting balloon and rota, assess the vessel again, and then understand this is actually, then we put it 2 stents into the circumflex. Then finally we did a kissing balloon inflation, and final angiogram created a lumen area of LED 13.52, circumflex 7, and in LMCA we produced a 17 millimeter square area. This another case, which actually in STEMI the patient came, patent stents. We should not think that only IVUS can do that. This is actually OCT imaging after LED pre-dilatation. We understand the segment area in this case. The pre-run LM, which is actually, the ostial LED was actually, you can see that it's only 1.95 area and 5.88, and we got 11.57 in LMCA. This is actually, the LM area is proximal LED is 2.99, MLA is only 1.95, and we could identify these areas. And the pre-run circumflex also we did, and this case 3.12, 1.55 is the tightest area, and 3.21. So that then we did a pre-dilatation with the cutting balloon in both circumflex and LAD, then crushed stent, first part, we did a decay crush in this case. Proximal crossing could be identified by the imaging. You can see that proximal crossing was identified by the imaging. Then we did a second KBD, final part, and pre and post images produced a result like this. And the final run, we got an ostium of LAD becomes 8.76 from 2, 13.08 distal LM, and proximal is 14.97. We did not stop there, and bifurcation final, this was the bifurcation angle. We saw the ostium is very good. Whether you require MCS in all these cases. You just look at this data, 90% of the cases which is done by every cardiologist in India requires MCS. Whether you require, data does not show that. IABP, all these things are. High-risk PCI without elective MCS is safe and feasible in most patients with a low rate of rescue MCS utilization. Findings suggest that routine upfront use of mechanical circulatory support for this population can be spared given this potential complication associated with MCS devices and additional cost. This is my strategy. This was a 67-year-old politician with a creatinine 1.8 to 2.4 with injection fraction of 22% came to me after rejected by surgeon as well as the cardiologist. So I was safe. This was angiogram. So there is a LMCA disease. You can see the diffuse LED disease. You can see a line. And this patient has a circ CTO with LED diffuse disease. And the patient came. We used a 1.25 Rugen balloon. You put a 2.5 into 26 or 0 stent. Then I did a 4 into 24 abluminous stent. I just left the patient with a 4.5 balloon dilatation and sent the patient away. And this was the final result. I did not touch the LED. I was focusing on the moderate MR the patient had. So after 3 months, the cardiac function improved to 45%. Patient wants to do other blocks because he is a politician. Decided I don't want to do it. By repeated requests, I decided to do it. This was angiogram after 3 months. So this time I took a 7 French GBU catheter. I put a wire into the LED, did a 1.25 balloon, 2 into 12 balloon. They could have done a regulating balloon. I did not do that. Definitely no stent was going because there was a stent inside the LMCA. I took a guideline up to the ostium of the LAD, taken a 2.25 into 40 abluminous stent. Definitely it is a very small vessel, and a 2.25 into 36 stent gone down. This was the result created. I knew that there is a lesion in the ostium of the LAD. I did not touch that. I left the patient like this. After 6 months, the patient had a mild chest discomfort, gas, TMD not done, echo cardiac function improved. Patient wanted to analyze the angiogram. I analyzed similar angiogram picture like the earlier picture before 6 months. I left him. I told I don't want to touch because he's a politician. After 1 year, again he came with an epigastric discomfort in 2019. This was the angiogram. This time I was actually more well versed with the imaging, so I thought I'll do an imaging for this fellow. So I understood the stented area has an area of 3.7 with a vessel of 2.2. I put a 2.25 stent. Very good. The medial LED reference was definitely low. So the LED osteoproximal part is very, very small. It is only 3 millimeters square. So I decided to do an IVS to the circumflex also. Then circ area is 4.3. Beyond 4, you can just leave it. And then what I did is actually a 3.5 millimeter balloon into the LED and 4.5. We did a tap stenting. And then with a port of 4.5 into 12, I produced a result of like this. Proximal LED 7.5, ostial LED 8.2, LMC 11.2. This was the final result I created. 2019, 5 years on follow-up. He is doing very well. But this fellow wanted to do an angiogram again. I did not do so far. Now the question is actually, I did not use an MCS for that patient. Calcium modification is safe or not? Basically, in aorta osteal lesions, a retrograde dissection from the coronary ostium to the ascending aorta is the most important point. Rotational atherectomy in LMCA is safe or not? Basically, the procedural success is very good. High procedure success with a low rate of fatal complication. In-hospital mortality was 0 and 30-day mortality rate was 3.1. What is the problem of rotational atherectomy in LMCA? Lack of operator experience, large mismatch, concerns about the no reflow, paucity of evidence. I have done more than 600 rotablations so far, so I have no fear. High risk for perforation, and ostial circumflex perforation is definitely a dangerous situation. I created that also. This is the patient. You just look at the angiogram, tight ostial disease, LED OM, tight proximally, and possibly calcified disease. I put a wire. You can see the favorable rota guide wire bias. I just see the wires. So IVS catheter was close to the calcium. So what I did is actually, I took a 3x6 cutting, Wolverine cutting balloon, but not able to dilate. So I used a 1.75 rotabar followed by cutting balloon. I created a distal landing zone understood with a 4.53, proximal is 4.88 and reverberation created, and even you can see the Wolverine cut in the third slide. And we understood that area. I took a 2.2 in a millimeter balloon. I just wanted to open the circ also, that is OM, large OM, but nothing was going. I took the wire out of the LED and then guide cell I tried. No balloon, was not able to track. So what I did is actually, now I have to use the rota. Since I am not rich, I have to use the same 1.75 rota bar into the OM. Many people will not be doing that. Try to take a rota bar distally, keeping away the LED wire, but not able to track down. I removed the wire also. That wire I removed. The only option is to remove the LED wire, and then I did a rota, then a balloon dilator, 2.75 into 18 stent I put, then finally I tried, not able to take the stent down. 6 French guide cilla, I took a 4.5 into 30 synergy stent because I have seen 4.66 is the area seen. This was a post stent. We got 14, 18.8, 10, very good area throughout. And this was the final result I created out of this patient, and patient is doing very well. Can I do IVL? There is an osteal disease in this OM. IVL in LMCA disease. A simple technique. Advantage is actually operative in large vessels, allows the presence of 2 wires, a low risk of no reflow phenomenon. What are the advantages? Drawbacks of IVL? Definitely when you keep long time, there can be ischemia created. So this is a case. An 83-year-old man CKD stage 4 at nephrologist follow-up, EF of 28%, not used any MCS. After few days of stabilization, patient was taken. I can take some time because Sandeep taken 15 minutes more.
There are a lot of people who are not there. So
No other speaker, so I can
no,
take
no.
enough
We
time.
have
Till you are
Mahesh
bored.
is here. So
So this is the RAO caudal projection. If you look at the RAO caudal projection, you can see there is something inside the LMCA. You look at the next projection. This is actually 83-year-old man, CKD stage 4. Now look at the LAO caudal projection. So there is a calcium nodule sitting on the LMCA, LAD and the mid part. So that is actually the circ and RCA. So elderly patient with a severe LV dysfunction, renal dysfunction, calcified vessel, IVUS guided zero contrast PCI with a calcium modification was my plan. So I wired the ramus and LAD with a filter FC using previous CAG reference. I did not take a single dose of, actually single drop of contrast. I put a rota 1.75 at 180,000 RPM. I evaluated the LAD, reverberations, calcified nodule changed. Then this is the situation. You can see the nodule now. In the third frame, you can see the nodule very well. So now I took an IVL. 4 into 12 IVL at 4 atmosphere. Naturally, that is the way it is done. Adequate luminal gain after calcium break with IVL. This was the distal landing zone I understood. So I decided to take a proximal landing zone. 52 millimeter is a stent size. Sepal wire I put for the aorto-ostial LMCA. I could not take a contrast. 4 into 38, 3 into 24 stent. Post dilatation with a 4.8, absolute zero contrast. I was run to LAD. We identified the area we got like this. 8.98, 11.76 and 14.21. So this check angio is for the money getting from the insurance. Otherwise they will not give money. Absolute zero contrast with good result with adequate. There is no pericardial effusion on follow-up. So DCB can be used in LMCA PCI. This is next question. Drug-coated balloon in side branch and DES in MB is one choice, or you can use drug-coating balloon in both MB and side branch as done by Praveen Chandra. But I will be preferable only to use the drug-coating balloon in side branch, not. This is a patient. Actually had a 99% ISR in circumflex and 70 to 90% ISR in LAD stent. This patient came to me, coronary angiogram done. Patient had a stent already in the circumflex. What we did is actually IVUS catheter could not be negotiated. I used a 2.5 into 12 millimeter balloon in circosteum. Nothing is going. Underexpanded stent, whatever actually I could gather from the IVUS. This is the area, you can see the area is very little and it is totally underexpanded. So then I did an IVUS to the LAD also, 6.69, 6.16, 7.6, 10.49. We did a cutting balloon there, 3 into 6 cutting balloon, 14 atmosphere, 15 seconds circumflex. Then I used a OPN balloon, 3 into 10 at 30 atmosphere. So we should prepare very well before using the drug-eluting balloon. 3 into 10 OPN balloon at 40 atmosphere, 3 into 10 NC balloon at distal circumflex. Then I did one more IVUS to understand whether I have done correct or not. Underexpanded area is well opened up. Post-open area, we got 6.94. Then I took a 3.5 to 12 millimeter balloon I did a kissing inflation before taking the IVUS again. There's a drug-eluting balloon. I got a 6.95, 7.19. Every step I do an IVUS. It takes some time. I put 2 magic touch together. This is the way I do. One magic touch I inflate for 1 minute. The other magic touch balloon will be there. The second magic touch I take another 1 minute. Then both together I inflate for 10 seconds. And pot. This was the final shot. Patient is doing very well. So ISR in circosteum was 3.69 became 6.48. LAD ostium 6.9 for an excellent mode of treatment in ISR. So drug-out balloon is actually one thing. In complex bifurcation, my point is 2-stent strategy. My technique is a DK crush or mini crush. Always go for imaging. Rotablation, cutting balloon, IVL depends upon the plaque morphology. MCS never used. DCB is used in selected cases. This case you just see. Ramus CTO, RCA. Okay, this was the angiogram. LM trifurcation stenting, initially in view of the ACS. Stage PCI to RCA was my plan. CABG was rejected by the patient because the patient is an acute leukemic patient on remission. Wound healing was the problem. So this was the actually guide catheter, ramus and LAD wire, 3 wires. Ramus tended with the 2.5 into 33 mini crush technique. Then I crushed that one. We did an IVS assessment of LAD. Not working. Okay, there is a stent, circ stent, mini crush, LM-LAD stent. You can see that pot in LMCA. Then final post tracing done. This was the final result. OCT done to understand what is the area. This is actually LAD area. We got very good area in the LAD part. And this was the last case I will show you, serocontrast PCI. This patient actually had a triple vessel disease. Patient actually has, this part is not done by me. This part is done by another cardiologist. They did an RCA intervention, but the creatinine gone from 1.9 to 3.2, single kidney patient. So the patient came to me for a serocontrast PCI. So I have taken the previous image and kept there with a wiring. LCX to LM IVS assessment. We understood there is a 2.29 area and 1.79 in the proximal circumflex. This was the area I understood. Then we did an LAD. This was actually the area created, 1.98 and 1.69 with a severe calcium. Then we did a ramus. We actually decided a cutting balloon and then did it. All without contrast. Then circ post CB, we actually shown there is a cut created. Then LAD again we did a cutting, pre-dilatation, stenting, ramus, 2 balloons, 1 stent, crushed. This is a second stent, crushed, third stent, crushed. Then recrossed through the first stent strut, second stent strut, all without contrast. 3 balloons together, kissing. Yesterday also I showed a tracing live. This was the area created in the circumflex. 8.89. I got a 6.14 in the proximal part and 4.81. This is ramus. I got 6.64 in the proximal part. LAD. This is circumflex. I got 5.4 and 4.9 distally. Contrast and fluoro is a contrast was a completely zero contrast, 33 minutes of fluoro and 3.6. Thank you very much for the patient hearing.